All right, folks, y'all have to bear with me on my voice. So I still sound like crap, feel like crap. So, and y'all can assume that I look like crap. That's the reason why I have my video on tonight. So we're going to talk about abdominal and genitalial injuries. I'll show you a couple of videos at the end. They won't show the part when it comes up about the videos. I won't show those until the end. But they're not too long. They're only like, I think 20 minutes total for the videos. So they're pretty educational. I think it'll help you understand a few things, and that's why I've included them. All right, let's see if I can push this button. All right, so we'll talk about, when we're going over the trauma is all about the same. We know supplying fundamental knowledge to the basic, provide basic emergency care to transportation based on the findings of acute injured patients. So genitourinary trauma and abdominal trauma, we want to know if we have penetrating mechanisms, blunt versus penetrating, evisceration, impaled objects. And don't just think about, like blunt trauma. This is going to go to both of them, to the abdominal and to the genitalia. So can't really have an evisceration on your, of your of your genitalia, but you can have impaled objects. So pathology and assessments of management, solid and hollow organs. What's the difference? How can you tell which one you're checking on? We're going to tell the difference between blunt and penetration, eviscerations, injuries to the external genitalia, vaginal bleeding due to trauma, and sexual assaults. The abdomen extends from the diaphragm to the pelvis. That contains organs to make up a path of the digestive and urinary and genitourinary system. There's a lot of pictures in here, so I like pictures if y'all haven't noticed before, and it helps me understand things a little bit easier. So I may talk fast until we get to the pictures so we can look at the pictures and go from there. Significant trauma to the abdominal let's just think about baseball, football, MVCs, MVAs, assaults, anything like that. So those are our classifications on trauma to the abdominal areas. Injuries to the abdomen can go unrecognized for a hot minute. Those are the ones that you may start having abdominal pain, secondary to an MVC later down the road, and you get a secondary call to them and trying to figure out why, like they're complaining of abdominal pain. Well, once you do your assessment, you're able to pick up, be like, well, they were in a car wreck the past couple of days, and once you see the abdominal area after you do your assessment, those are the ones that's going to tell you that you say that, oh my God, there's some significant bruising there. We know that that's signs of internal bleeding. So that's going to require a rapid transport to the hospital, potential surgery. And if it's not treated over time, and maybe it's just something that they don't address over time, that it can lead to death because of the massive blood loss into the abdominal cavity. So the anatomy and physio of the ribs, of the abdominal quadrants. So the abdominal is divided into 4 quadrants. The quadrant location of the bruising and pain can delineate which organs are possibly involved. So what I'm trying to say is, if you'll see on your screen, you see that you have the RUQ, LUQ, LLQ, and the RELQ. Those are separates between the right upper, right lower, left lower, and right left upper quadrants of the abdominal area. Here you go. So now that you see this, and you can be able to tell different parts of the abdominal cavity of which organs are located in which areas. So if the patient's complaining of a left lower quadrant pain, when I go to palpate this area, I don't want to start on the left lower quadrant. I automatically want to start on the right lower and work my way up and around to the left lower quadrant. So hold on a second, y'all. They're across the street if you want to go. So if I started on the left lower quadrant, anywhere else I touch on this patient is going to be tender. It's going to hurt. So every area after that is assessed is going to be very tender. So that's the reason why we've decided, hey, it's probably not, let's start in a different area and work our way around. So working our way around does help, still may mask some of the pain due to the pain in itself depends on if it is a referred pain. And what we mean by referred pain is you can have different, let's say like jaw pain can be indicative of a gallbladder issue, heart issue. So those are called referred pains. But if they're specific saying it hurts 10 out of 10 right here, like it's unbearable. Okay, so that's my 10 out of 10. So hollowed organs. So the hollow organ is the abdomen, includes the stomach, intestines, uterus, and the bladder. When ruptured or lacerated, the contents spill into the peritoneal cavity, causing inflammation and possible infection. So the infection is peritonitis, severe abdominal pain, tenderness, and muscular spasm. Just as a FYI, keep this stored in the back of your mind that if you have a stomach injury and somebody shows up to give them, they can medicate them, give them narcotics because of their pain. Make sure that you're very smart about what they give, and just know that morphine is a smooth muscle agitator. So when you give that, when your medic or somebody else shows up and they complain out of more and more pain, well, just understand why, because now you just gave that smooth muscle agitator into a patient that's already having abdominal pain. I learned that from personal experience. So be cautious of that. And if that's something that's needed and or required, let's see what other options there are, because that's probably not the best medication to give them. We have other pain medicines out in the country that we're allowed to carry that will help fix that. So hollowed organs, they include intestinal blood supply, comes from the mastoid, which is the fold of the tissue that connects to the small intestines and the abdominal wall. Patients with injuries to the mastoid can bleed significantly into the peritoneal cavity. Whew. Signs include abdominal rigidity and pre-umbilical bruising. So look, that's why I tell all y'all all the time, please do a good assessment. Make sure you lift that shirt up. Don't disrespect them and leave it, but at the same time, be like, hey, look, I really need to check this area. I'm going to raise it up and I'm going to poke around. Now, remember the different religions. Sometimes it's hard for them to allow another man to assess them, but a lot of times people kind of forget a little bit about that when they're in so much pain and they call for assistance. But again, respect them and explain everything you're going to do to them prior. I know I've told y'all in the past, there's a particular person that she is my go-to person. I work with her all the time. She's a female, love her to death, think the world of her. I call her my little sister, but she's the one. And the reason why is I trust her. I know that she knows her stuff. She wouldn't do anything to jeopardize either one of our careers, our livelihoods. And I probably let her do a lot more than I would ever allow anybody, because it's, even with another female, they're just that more comfort level. So specifically, if you're inspecting their abdominal cavity or anything like that, just think about how that may potentially come for safety reasons, for comfort reasons. So those may be some of the things that you may see. All right, so here's some anatomy and patho of the abdomen. These tells you which hollow and solid organs are located in what areas. You see on the right side where your spleen's located. You go to your liver, your adrenal gland. So these may tell you when they start hurting in the upper right quadrant, is it because of the spleen, or is it because the kidneys are starting to have issues? Most time your kidney pain is going to be in the back of their body is what's going to hurt the most, right around the waistline. If you'll look also, you have your stomach, your large intestines is also, like a quarter of it is also in the left quadrant. And then you start getting further down, and you not only in this picture, you have your female reproductive organs and you also have the same thing as the males have. It's just they have a lot more. It's a lot more complicated. That's why I always say learning the female anatomy and women in general is the most complicated in the world, because they got more, and we just simple-minded men just don't understand all that. So that being said, is just knowing your placement and knowing the location of things will help you out tremendously. So solid organs. So the solid organs of the of the abdomen include the liver, spleen, pancreas, and kidneys. These organs perform the chemical network of the body. So you have your enzyme production, you have your blood cleansing, your endocrine functions, and your energy production. I think my energy production has quit. Because of their rich blood supply, hemorrhage of the solid organs can be severe and is going to dump into the pleural space. So think about that. Retroperitoneal space is the posterior aspect of the abdomen and behind the peritoneum. And this contains the kidneys, uterus, urinary bladder, and the majority of the pancreas. We will watch that in a minute. So injuries to the abdomen are considered either open or closed. They're going to be, their gross. Abdominal injuries are considered, I already said that. So can involve the hollow or the solid organs there. Closed abdominal injuries. So we're going to go over the blunt to the abdomen. MOI is capable of causing closed injuries or motor vehicles, motorcycle crash, falls, blast injuries, pedestrian versus bicycle. I've never really worked a pedestrian versus bicycle. I've seen pedestrian versus motorcycle and car, and those are really nasty. Rapid deceleration, compression, those are very gross too. They may initially appear as abrasions to the surface because they got hit and bumped to the ground, and you got to think too how tall this person is and what is their proximity of their body to a certain part of the vehicle. So that being the case, were they like a small child that could have had chest and head injuries from hitting the car, or was it an older person that's going to have abdominal to thigh issues? So it may take several hours for the contusions or the hematoma to become visible, but be very cautious and don't let that slip your mind. They may initially appear as abrasions to the surface of the skin. The abdominal distension is often a result of free fluid, blood, or organ content spilling into the peritoneum. That's the reason why we ask you guys to palpate their stomach. Is it soft and rigid, or is it, does it feel like it's firm and it's painful? Well, I mean, does it have a temperature? I know that our core is always going to be warm. Sorry, I'm having to drink a lot more. It's just because my throat hurts so bad. So we know their stomach's going to be warm, but does it have a fever? Because that's our core. It's always going to be warm, but is it like abnormal? Like, man, I don't know. This don't feel so right. So we pay attention to that, and we want to make sure all things are good. Let's see here. So seatbelts are probably our biggest issues, along with airbags. When worn properly, seatbelts lies below the anterior superior iliac spines of the pelvis against the hip. Or I don't know. Here's a picture coming up because that was a little rough. Here we go. So you see why we're gonna have the issues here. So on this picture A and B, you see you're gonna have stomach and abdomen issues here. And remember specifically, like if the female is pregnated and they have a child here, the seatbelt should be postured completely different. Now, if you have in figure C, you're going to have a pelvic, more of a low griddle pelvic area pain. And you can tell why the different areas of the body are going to be affected due to the seatbelt positioning. What you need? So injuries to the foreign object enters the abdominal and opens the peritoneal cavity to the outside. So that's automatically introducing an infection. It's automatically introducing the outside to the inside, where it's supposed to be, warm and sterile and clean. Now the outside is nasty, dirty, and gross, and it's being introduced to that. So just remember, you're going to have a big time infection. You need to maintain a high index of suspicion for the unseen injuries, because the ones that you see will draw your attention and suck you in. Internal damage to the organs and potential life-threatening issues when not addressed in a right amount of time. So the damage depends on the velocity of the object. It's caused by the handheld or hand-powered objects such as knives and other edged weapons. Women stab in the downward motion, men stab in the upward motion because of the height difference there. So keep that in mind. So you have your medium to medium velocity injuries, and that's a small caliber handgun and shotguns. But I'm kind of going, the shotguns can, if you know a lot about guns, you can understand that shotguns are improved over time, and they're not given the reasons what they are. They have some shells that shoot super hot and that are almost just as fast as a 380. So you have still, that's kind of your the shotgun kind of throws me off to being in a medium velocity. But the high power, they're talking about high powered weapons such as rifles and high powered handguns. Those are going to be in your high velocities. High and medium velocities have temporary wound channels in addition to the exit and entrance wounds. So what they're saying is it's like taking a bar and you shove through somebody's body. Now you have your entrance and your exit, and that is your tunnel. So when you have these projectiles, they do create cavitation and they cause a pressure wave. Now you can have just as much, if not more, injuries from that cavitation and pressure wave than you can do just as is the rather open, the entrance and exit. The higher velocity of the projectile is the larger the cavity that is produced. So if you know, let's say, if anybody knows anything about handguns, again, not debilitating anybody's knowledge, but you go with a 22, which is a very small caliber. Yes, you can still kill somebody and you can still kill an animal with that, but that is one of the smaller calibers that's out there. So if you take that versus a 357 Magnum, the size of the bullets are drastically different and very different. So it's like taking a 16-ounce cola, that sounds very bad, a Coke, and then you take a 2-liter Coke. Those are the difference in sizes. So you can imagine how the cavity and the cavitation is going to be affected by those two differences that enter and exit the body. The only bad thing about the 22 is it's going to hit inside and bounce around. I'm not saying that it won't potentially do a through and through. It just depends on where it strikes the body. If it strikes it in the abdomen or a bony area, you're most likely going to have that 22 hit a bone and bounce around. So it's going to carry around throughout the body versus that, that 40, that 45. It's going to go straight through and take bone with it. And on the way out the door, and it won't say thank you, ma'am, for your time. It's just a very big gun of caliber. So low velocity penetrations also have the capacity to do underlying damage to underlying organs. Whoops, sorry, that was on my screen. I apologize. So at any time a patient has an injury at or below the xiphoid process, it should be assumed that the thoracic peritoneal cavities have been damaged. So when it says violated on my side, and I don't like the word violated, it's just like, what? So when you do that, you need to make sure that anything from the xiphoid down, that you're potentially going to have organ damage. So solid or firm, it's going to potentially cause issues. So that could warrant you to up your progression to transport at a faster rate. Any GSW unknown caliber, even if you do know the caliber, still should warrant you to transport your patient to a trauma facility under your GSW status. Each agency has their own GSW status on how to transport and what facility is required. So know those, again, know your local protocols before you have once you get on your truck, you need to know your protocol. So an evisceration is the bowels that come out of the stomach. That is not where they're supposed to be. I have taken care of multiple of these. They're initially pretty like, oh God, what is that? But it says here it can be painful and it does look very, very visually shocking. I promise you it is. But do not whatsoever ever push that back into the body. Even if you show up and somebody's trying to do it, stop them. And you want to keep them covered. I don't know if it's telling me about that in a minute. I don't want to. All right. So anytime there's an evisceration, you want to keep them wet and covered because we're trying to keep them from becoming infected. We're trying to keep them from having any contaminants put on there because they're going to clean them and stick them back in at the facility. But we don't do that. That's not. And never pull on any clothing that's potentially stuck inside the wound. Maybe it's got a cavitation that has sucked the shirt back into there or the clothing. And you can give a small to little tug to it. But again, I don't want you to be like, all right, we got to get this out of there. No, if you can't remove it with a light amount of pressure, leave her be and continue on to the next thing. Make sure you point that out to the facility when you arrive. Guys, I gotta put y'all on mute for a second. I have to blow my nose. Just stand by. All right, sorry about that. All right, so hollow organs. So often can have delayed signs and symptoms. They commonly spill contents into the abdomen, which does develop into infections. And these are going to be your days to hours to, I want to say a week. You're probably most likely going to see these damaging infections. About 5 days. It takes anywhere from 3 to 5 days for a new medicine to get into your system. So it's the same thing on an infection. You can anywhere look from 3 to 5 days for an infection to set in and you start getting noticeably ill. So these may be your secondary EMS runs. You may work at a primary station and you work there every, I don't know, let's say third day. Let's say you do 24-hour shifts. Well, you go to the MVC and then the patient's like, no, I don't want to go. And you're like, hey, look, I noticed your address. You actually live right around the corner from the station. It is your right to tell me no. It's 100%. I will tell you this. If for some odd reason you decide to say no, once we get back to you to do your refusal, I will tell you, you can say no to me once, but if I come back to you for a second time within a 72-hour span, you have to agree to me that you will go with me to the hospital. Other than that, I will call my medical director and we're going to end up talking about it. And due to the location of the injury and what you're describing, I can get him to tell me that I have to take you to the hospital for your safety. So most of the time, people are pretty cool about that. So even when you do show up later down the road, they're already like, I already know. I know what you're going to tell me. I know that I need to go to the hospital. So they don't really fight that. They're just more cool with you and like, yeah, I know. It's time to go. So all right, so hollow organ injuries. So both blunt and penetrating trauma can cause hollow organ injuries. Blunt trauma causes the organ to pop, releasing fluid in the air. It's not something you're going to hear, obviously. It's something that they potentially may feel. But penetrating trauma causes direct injury, such as lacerations and punctures. The gallbladder and the urinary bladder are hollow organs which contains are potentially irritating and damaging if ruptured. So you got to think about this. If you've got your gallbladder, which we know what gallbladders do, I hope you all do, and you know what the I just lost my spot. So you know what the bladder does. So it holds all of these, and once it gets released into the body, if your gallbladder quits working or it's lacerated and it starts dumping bile into you, you can get pretty sick. Same thing with urine. It's not gonna like, oh my God, it's gonna make you sick. There's urine in my body. Well, that's where it's supposed to be, truthfully, but not like in your body. So once those things get out there, 3 to 5 days, you'll start noticing some issues and be like, man, I just don't feel good. And you'll notice that throughout the time. The patient will. These fluids move into loose spaces and voids into the peritoneal cavity, eventually leading to the infection. Uh, Free air of the peritoneal cavity produces pain. That's where you're like, ow, that kind of hurts. It's kind of like a gas pain. It's the same thing that every one of us affects and feels. And you're like, oh, what was that? A gas bubble moving inside your body. Usually it indicates that a hollow organ or a loop of the bowel has perforated, not what I was just explaining to you. But yes, that is also because of the free air. If not rapid identified, the repair severe infection and septic shock may develop. You are probably going to see these patients in septic shock because of their initial refusal to go to the facility. Now, it's not going to say that these patients are going to be, that is going to be found on arrival to an ED, because they're going to check them out and they're going to feel around, they're going to do a couple, but what happens if they don't see that laceration or the spillage hasn't come out yet? So again, you may see them in 3 to 5 days with those issues and complaints, and that's normal. They went to the facility. You're the one that took them. And now they're calling you back because they're having abdominal pain. Well, if you don't do a good enough assessment when you check them out, you may not even notice that, or even come to find out on your history exam that they were involved in the accident. So that may be something that you start asking certain questions on how you're going to fill those out. Solid organs can bleed significantly and cause rapid blood loss because it has no way to stop. There's nothing there. They're full of blood. And it can be hard to identify physical exam because the patient is not experiencing much pain at the time. Solid organs can also ooze blood into the peritoneal cavity, causing pain to increase slowly over time. Now, it may be that they move in certain directions and that's how they get the blood, or when they lay flat, it starts to hurt worse. Well, that would be understandable because you're taking the pressure off your organs from you standing up and down. You may not have no pain. As soon as you lay down, start to have issues then. The liver is the largest organ in the abdomen, very vascular, and can continue to hyperfuse if injured, and often injured by fractured lower right rib or penetrating trauma. Common assessment finding is referred pain to the right shoulder. So as we talk about that, there is a referred pain. So if they start saying, man, my shoulder hurts, it's just, I can't tell you where, it's just like my shoulder always hurts. Well, think about that, because that is a referred pain to let you know the location. And you'd be like, you have any trouble with your liver before? And they're like, what? No. Because that's not what normally comes out of our mind, is thinking that, oh, we think they have a liver pain. Well, there's a reason why I asked that question. It's the same thing as a referred pain. And then you ask them more questions and you go into detail and they're like, oh, well, I was in a car wreck a couple of days ago. I didn't go to the hospital because I didn't hurt. And that may tell you some other reasons there. So the spleen and the pancreas are very vascular. We know these are going to bleed very profusely because of what they hold. Both are prone to bleeding when fractured, lacerated, or punctured. I'm not really sure how you fracture either one of those, but I'm going to go with what they say. But referred to the left shoulder, pain also comes in small splenic injuries. So it's not just your liver that's going to be referred pain there. There's other organs and other tissues that may show you those referred pains. I can't tell you why those are referred pains. I have no idea. Couldn't even go off and tell you why. If somebody else does, that'd be amazing. Maybe I can learn something tonight, but I will definitely listen to y'all if y'all know. So the diaphragm, we know the diaphragm keeps us alive because it contracts and relaxes, and that's how we breathe. Patients with diaphragm issues may have dyspnea. They may have also penetrating ruptured of the loops of the bowels and may herniate into the thoracic cavity, which is causing issues. Change in position from upright to supine results in abdominal contents spilling into the thoracic cavity and compressing the lungs, prohibiting the lungs from fully expanding, because now you got crap in your body and you can't breathe. So crap is suffocating me. I can jokingly say that because I'll say a couple months ago, that's probably been a year ago now. I had to go to the hospital. My small intestines just went to sleep and didn't wake back up. Don't know why. We think it was because of a new introduction to a medication that I had taken. That was one of the side effects after the fact. But I was full of crap. Had to have it sucked out my nose. That was very, very painful. I promise you. I don't wish that on nobody. So the kidneys can be impacted by penetrating trauma. So, I mean, every organ on the inside of your abdominal cavity can be affected. So common findings is blood in the urine. Blood visible on inspection of the urinary menace indicates significant trauma to the genitourinary system. Now, I will also tell you this, side note. I'm full of different side notes. If anybody takes B12 on a regular basis and you've ever noticed your urine's a little red, that's fine. That's part of the body saying, hey, I'm full. I don't need no more. We're going to top off. So I have always asked somebody what color their urine is. You know, it's a little light yellow to pink. Okay. Have you had any issues with vitamins? Do you take any vitamins? If they say I'm on a B12 injection, I normally don't go any further than saying that, oh, you may have issues to the kidneys, because that's normal on somebody that gets a dose of B12 on a regular. You should see depends on how regularly they take it. But that's just their kidneys saying, all right, I'm full, got to pee it out, it's got to go somewhere. So in the patient assessments of the abdominal cavity, we talked about that. We know how to start assessing that through your quadrants, the farthest to the closest. It's going to be very painful. It's going to happen over time, and you're going to see these patients again 3 to 5 days later, because of this. Just the issue's going to continue to get worse over time, and then they may not be able to handle the pain and be like, look, I can't handle it no more. I got to go to the hospital. Okay, well, they call an ambulance, and that's where we come in. We get to go get them. So seam size up, be sure you've seen it. We talked about this before. We know how to do seam size up, I pray. Again, y'all, I don't think we need to go over this as much about the history taken. Hold on, give me a second. I'm catching up on your mess. Stand by. So make sure when you do your primary assessments, y'all, is just put your hands on them, touch them, make sure, because if you document me saying no injuries found and they go to the facility and they come back on you later because you maybe didn't check on them correctly, you didn't assess them right, you just didn't do something that can come after you. So again, put your hands on these patients, make sure that they're good or they're not. I mean, if you didn't touch it, you may not have been able to do that. We'll go there. I'm going to skip that. I'm going to skip that. We'll go here, and then it should get us a little bit, and we'll take a break. So how you take care of closed injuries. This is what I want you to start thinking about your care now. So what you're going to obviously do is monitor the patient, evaluate progression to shock. Now, we're not going to know that these are potentially, we're just besides a GI complaint. That's really all we're going to know, because we don't have the signs and symptoms, the tools to tell us on the ambulance that this is what they truly do have. Vitals very often, and notice if there's any difference in change of these vital signs. Always keep the patients who are on oxygen. If they're unconscious or going worse and you can detect them changing into shock, you know that we have to up our game there and start doing true medicine and taking care of patients and treating them to be their best. Keep the patients warm, assist in ventilations if necessary. Consider calling ALS for placement of oral or nasal gastric tube. Um, some services allow that. Not all services do allow that, but this is just something that you can think about. If your agencies do allow you to do nasal gastric tubes, that's fine, and it's not like it's super duper hard. I've done a couple of them, then I had it done to me. They do suck. The best I can tell you is I don't ever in my life want that to happen again. It's horrible, but I've had a lot more worse things done to me. Um, so keep that in the back of your mind. Patients with penetrating injuries, remember we don't move those. If you can see it, if it's a through and through, like a stick, a limb, pole, metal tube, something to the fact, we leave it in place. We want to make sure we stabilize it. We don't want it to jerk. We don't want it to vibrate. We want to do everything we can to keep it there. Pat around the area, control the bleeding if you can see it. And you know that there's going to be blood loss on the inside because of what it's just think about the area. We know we've seen the abdomens and that stuff, so we know the area that is penetrated, and it may have affected the spleen. Now it could have nicked the spleen and hold pressure against it as the tube's there, but keep those in the back of your mind. Follow general procedures described previously. Care for blunt injuries as well. Inspect the patient's back and side for exit wounds. Look if it is a GSW. Please make sure you look everywhere you can. If it is in the stomach, you want to take the patient's shirt off. You want to look into the underarms. You want to feel the ribs. If you can't see, put some. I carry a flashlight with me 24 hours, 7 days a week. People make fun of me, but I've been in places to where I've needed a light, and your dang cell phone light ain't bright enough. It is for the safety of me and the patient because things happen to Chris Wally, and I'm always in shitty situations somehow, some way that I've just learned there's certain things I keep on me at all times. So I highly recommend you get you a cool, nice little flashlight, keep in your pocket at all times. Not something that it's required. My Chris Wally isms that I've been told that I have, that those are very important to have so you can see and check, inspect areas. Now, this is an evisceration. And if you notice, this is the intestines that has popped out of this. I'm going to call it a man. I don't know where on the body that is. That appears to be his nipple. So I would assume, I don't know where this is at. But we'll just take it as it is. Who knows? But that's an evisceration. So here, all these bandages, if you'll notice how they're little, they appear to me to be a dry dressing because that right there looks like it's stuck. But you always want to make sure you apply a wet dressing. I despise the word moist, so but make sure the dressing that you put over here has been wet prior to adding on top of these organs because they will stick to them, and the surgeon will cuss you. It doesn't really matter to you because you don't know them, but they'll cuss you for everything you're worth as the patient's getting ready to have surgery, and they have to clean every bit of that. Never, obviously we've said this before, never replace the protruding organ. Keep the organs wet and warm. Cover the wet and sterile dressing. Secure the dressings with a bandage and secure bandage with tape. So I have tried that before and it didn't really work the best with tape. It just was not. I just literally told the patient, hey, hold these in place. If you don't hold them in place, it can cause you some serious issues in the next time. Because taping something over there, no matter what, tape does not stick to a wet dressing. I'm just gonna let y'all know. I don't know if y'all have done this before. Y'all have better ways to tape than I do, but you don't want to even use the cling wrap because it's gonna potentially shift on. You don't want to hold a lot of pressure on there because you don't want it to accidentally get a negative pressure. And when I say start sucking that back in there, that's not what's going to happen. But you don't want any part of that that's already protruded to be returned back into the body.
Hey, Chris.
Hey, talk to me.
What if you were to put like the big Telfa pads over the wet dressing, because those aren't sticky, because you already got your wet dressing over the organ, and so you put the Telfa pads over it and then you tape? Would that
I'm
work?
not gonna argue with you. If you see here on this particular picture, they're talking about covering it. Now, I like using the big abdominal trauma pads, and I wet them and then lay them down. So if your agency has got that, now I know that we may all have our sources to get other supplies, and I've used things that I've brought back from the Middle East to take care of patients here. But at the end, if I go to surgery, or if they, something happens and it goes back into a court case, they're, well, where did you get this particular tool from to use this? And you're like, it was on my truck. And then the agency's like, no, it's not, because we don't have that. Hey, you know what I mean? So that may, and again, it may be well worth it. I mean, that may be something that is 100% on point and game ready to go. And if you have that on your agency, do it. Write it out, girl. I have no problems with that.
I just didn't know if it was something that you had ever tried before, or if y'all even carry like Telfa pads on there that are big enough for, like, depending on the size, obviously.
Yeah. I've used a few things different in the Middle East. I actually had my second case ever. An Iraqi got shot by an AK and his intestines started coming out. And we actually used multiple trauma pads. Actually, the surgeon that was there with us, he actually said, hey, staple those together before you put him on there. And all of us are like, wait a minute, what did you say? That's metal on him. And he's like, he's not going to be doing that much. We're going from here to surgery. So we're not going to staple them on there because in the fields, we don't carry staples. But if you do have that pad, do it, girl. I think that's an amazing idea. Trauma pads, ABD trauma pads are probably the biggest that I know that you may have access to on your unit. Now, again, these are something that's going to happen probably maybe a day or two after surgery, where they may sneeze, the suture may not be right, or something to that effect. You may see these also too on a C-section. My very first one was on a C-section. The lady left our trauma hospital, went across the street, told her husband, I want a Wendy's burger, and you're not going anywhere before you get me a Wendy's burger. And in Wendy's, the line, she sneezed and her tummy popped open and said, surprise. She was eating her Wendy's burger as we pulled up together, to be honest. So that's the only few that I've had in my life. So going over to the genitalia. I mean, this is pretty cut and dry right here, y'all. Here's the male reproductive system. I mean, we all grown folks. At least we should know how the male and female reproductive system at least works. Where the particular, I'm pretty sure you'll never on registry get asked where your seminal vessel is. A&P may ask you to label these when you go through A&P to prompt for paramedic school. It's just the frontal and the side view. There's the female's reproductive system and the genitalia. It's really cut and dry. I know that's not really that detailed, but I mean, it's pretty simple as to tell y'all what's what. Let's see here. Kidney injuries. They're not uncommon and they do rarely occur in isolation. Kidneys do they have to take a forceful blow to penetrate the injury? It's not really common, is the best I can tell you on that. It says less significant injuries can result from an indirect blow, such as a football tackle. You may see that from a side injury to a side to rear, to where they're struck and get an isolation injury to that way. So you're not really, you may have some bruising. If you happen to see any abrasions, lacerations, or contusions to the flank, that's going to be issues there. Fractures to either side of the lower ribs may indicate a lower thoracic or upper lumbar vertebrae fracture. A hematoma to the flank region. Now, if you start to see pooling of the blood or massive bruising around that area, you need to ask them what kind of traumatic issue they've been involved in. Specifically, what color is your urine and what does it smell like? Because if there's any type of issues there, that urine's going to smell. I'm pretty sure majority of us in our adult lifehood has gone to the restroom and you're like, oh, God, I need to drink some more water. Maybe after a long weekend, I don't know. But I know I can say comfortably that all of us in our lifetime has dealt with that. Let's say urine spills in the surrounding tissues area. In males, sudden deceleration from a motor vehicle or motorcycle crash can shear the bladder from the urethra. In later trimesters, the pregnancy, the bladder injuries increase from displacement of the ureter. Blunt injuries to lower abdomen or pelvis can cause rupture to the urinary bladder, particularly when the bladder is full and distended. Here's the placement of the bladder. Here is where it shows that it has been punctured. There's actually a perforation. You have from the back, the pelvic has been broken here, as you can see. So the bone fragment has actually punctured it. As you can see, it appears that there's 2 pieces of bone fragment that is missing, and one has ruptured the bladder. Urine's leaking out into your pelvic girdle down in here, and that's where your infection can come in. This right here will be 150% painful. So the leaking of the urine is not their number one problem. I can promise you that. You're going to have notice some soft tissue wounds. Pain may be referred to the lower abdomen. This should not be given priority over more severe wounds unless there is significant bleeding located. In the female genitalia injuries, the uterus, ovaries, and fallopian tubes are rarely damaged, small, deep in the pelvis, and well protected. But some exceptions is a pregnant uterus. The uterus enlarges substantially and it rises to outside of the pelvis. Injuries can be serious, causing the uterus to have rich blood supply during pregnancy, and it's also keep the fetus in mind. So any type, I have said this and I will always go down with it. If I pull up to any female that's been involved in a wreck, I will make it. I try my best to always make them go to the facility with me. Now, stand by. I have to blow my nose again. All right, everybody, if y'all can see Caesar's note to the class. Yes, the GI patient, they produce a ton of blood. And you remember, that's a lot of cavity for blood to fill. So we're like, oh yeah, it's going to hold a lot of blood. And I guarantee, Caesar, you were like, God, that's a lot of blood. And it doesn't take long at all. It's very quickly that it can fill up an area. Let me change this around. There we go. All right, so let's see here. Anytime, so what I was saying, so if a female's been involved in a motor vehicle collision and they are at any type showing pregnancy, I always try to make them, let's go to your hospital and get you checked out. Now, if a spouse or a parent pulls up and they're like, we'd rather go straight to the doctor. We've already talked to the doctor on the phone and they're waiting on us. I don't have a problem with that. But what I do is I make the patient and the other party involved sign the refusal form. And the reason why I get them to sign their refusal form is so when I document that patient signed the informed refusal and understood all cost of signing refusal form and refusing transportation to the medical facility. And so did patient's mother. She signed saying that she understood that she was taking care of the patient in her possession at the time of refusal. So I document that, and if there's, I don't ever let like certain, well, I say this, there's certain ones that I let sign on their own, but if there's family around, or obviously if it's a juvenile, so if they're 18 or older, they can sign the refusal form. But if a parent shows up, I'm always going to get that parent to sign it also. It just helps me out for documentation later down the road. So external female genitalia. This includes the uvula, the clitoris, and the major and minor labia at the entrance of the vagina. Very rich nerve supply, so injuries are very painful. Consider sexual assault and potential pregnancy. Ask the patient about the last known menstrual period. Ask about sexual history. Now, again, be very cautious because those may not get answered if there's the potential attacker around and or family that they're trying to keep it hidden from. You can also think about abdominal injuries there as an ectopic pregnancy. I've always said, and I'll stick with this, if they are of childbearing age, everybody is potentially pregnant until proven otherwise. I have had women tell me, "Oh, I can't have kids. It's not possible." Well, do you have the scars saying that they took it all out? Well, no, but then it's possible. There's always a chance until you've had all your stuff removed. Now, granted, maybe I can't, and I've had a vasectomy, but my wife can. So at any point in time, I've told her they're gonna pregnancy test you no matter what. If you have to go to a facility and you've got abdominal pain, you're gonna get a pregnancy test, and we both gonna be shocked as hell if they say you're pregnant, because we're gonna be like, So, and just knowing if they are childbearing age, you have to think that they are pregnant until otherwise. Do not insert any type of instruments, glove, fingers, or tampon into the vagina if there's any type of bleeding. I don't know if this covers this, but I'll talk about this. If the patient has been sexually assaulted, do not allow them to change clothes. If they get there and they're already been showered, please try to take those clothes with you to the facility, put them in a paper bag, not a plastic bag, and control the scene. If they try to tell you to put their hands in a paper bag too and take them up, there is no way in hell that I would do that to a woman that has just been assaulted. Not happening. I am going to instruct her if she's comfortable enough with me. Ma'am, listen, here's what's going to happen. You need to understand. I'm going to take you to a facility where there is a SANE nurse. I can't tell you the abbreviations, what SANE stands for, but it's like a sexually assault nurse. They know everything. They've been down this road, and they're going to walk you through it with everything possible. Now, what I need you to do is please don't start digging your fingernails out. Please don't scratch your hair. Please don't do anything. If you potentially are bleeding down there, please let me know. I would prefer you look versus myself. And if you are, I will give you a bandage to place over the top of your area, and let's ride like that. Please don't insert anything. I have done that. And then what you can try to do is tell them, just be very honest to them. Don't do anything quick. Don't do anything behind the patient. But you have to tread on water about that because of the sexual assault. It's the same thing can happen to men, but it's more predominant in women. So if they're very shy or sheltered when they come to you or they call you, it may be for something else. And then when you get them alone or try to talk in the ambulance, You may have an aggressor that says, no, they don't need to go, and or they're not riding without me. Be like, sir, it's our policy. You know how, I mean, we've talked about this. You just have to try to make it where that patient is the safest. And then once they get alone, they may be able to tell you more information once they get alone. So potential for patient, yeah, so be careful. You know that you maintain your professional abilities. When it's possible, have a female, an attendant of the different sex try to perform the assessment. Now, if for some odd reason that there is not another one, as you can tell, I'm a big advocate on working with a female partner. It's important that you have them do the assessment over you. Now, if you don't, you may just have to tell them what it is and rock along with it. All right. So, emergency care for the genital injuries, kidneys. It's not going to be obvious. We're not going to know what's going on. I'm going to give y'all a vote again, guys. I have 2 videos to show you. We're on slide 72 of 87. Y'all want to keep going or you want to break?
I say go ahead and finish up.
Yeah, keep going.
Oh, come on. I know you ain't trying to hurt no watch no LSU game. Chill out, bro.
Nah, I'm trying to go to bed.
Yeah. So look, again, I'm gonna show you these videos. One of them is pretty long. It's about 15 minutes, but I really think it helps you understand things, and the other one's about 6 minutes long, so it's not a whole lot. Okay. Caesar, you're more than helping. You're more than welcome to get up, and walk around, bro. I have no problem whatsoever. If you, I mean, I'll tell you what. I'll make a deal. I'll talk slow, and we'll. If you have any issues, you can come back and catch up on it. Is that okay with you? Man, I can't ever tell somebody they can't get in the bathroom. Come on, you know, I'm here for you, bro. I just wish my nose would start running, and then I'd be happy. Where am I at? So kidney injuries, y'all, we're not gonna notice that. We're gonna see them in the late signs. You're gonna see them in shock. The only thing that you're gonna notice on this is going to be late signs, and your vital signs are gonna be like, you know, this just doesn't look right. Something's up. I gotta see what's going on, and we don't know. So monitoring your vital signs are going to be your issues. Urinary bladder injuries, blood is really going to be the easiest thing. Now, I'm not going to be like, can I see? Make sure there's no blood around the opening. No, I'm not. No, there's just some things in life that I just don't want to see, and particularly to check your urethra opening is one of them. That's yours. You should be able to tell me what color your urine is. I'm sorry, ladies, even if you do sit down, you stand up at some point and you can see, oh, that's not the right color. I'm cool with that. You ain't got to save it for me either. I get enough urine offshore that I don't care to ever see another bottle of urine. So if you have potential presence of shock, transport. Monitor your vitals, put the patient on high flow O2. So the external male genitalia, a few general rules here is to treat the injuries to the external male genitalia. Injuries are, now this is, I'm gonna tell y'all ladies, I know y'all are a lot stronger than us. Y'all have babies, but I have the man flu. I swear I do. So my wife, she just don't get it. So I'm gonna tell you, when we talk about here on these male genitalia, it's painful. It's super more painful than y'all will ever be able to understand. And we have more problems than y'all do in childbirth. So know that our pain levels suck. So use sterile and moist compressions to cover the areas stripped for the skin. Now, that being the case is understand that you do have a lot of lacerations and or potential skin tears from trauma to the genitalia. So if there's issues where you've had I just went blank of, I can't remember now, where they had a degloving of the penis. For someone who knows why, maybe it was not where it's supposed to be, or it was intentionally done that way. Those are going to be very, very bloody. They're going to bleed a lot. You jokingly say, but truthfully say, apply direct pressure with jaw sterile gauze to control the bleeding. The more you manipulate the foreign objects in the urethra, I have seen x-rays to where things have been stuck in the male urethra openings. Don't ask questions no more. I've done this so long. I just take it for what it is and go with it. But understand, some things are done for stupidity and some things are done because people just don't know no better. They learn after the first time. So to control the bleeding, because a lot of times the male penis is going to bleed a lot. It's very venous. That's what controls it. If there's traumatic issues there, you are going to have, the patient is utmost screaming, hollering, yelling, and all that. And so they're going to be very cautious and they're going to be screaming out their wazoo. So fair warning. Otherwise, the majority of the time, women can be like, you fine, you be all right. Let's move on, bro. So identify and take the avulsed parts to the hospital if the patient, if the avulsed of the skin is on the penis, wrap the penis in a soft, sterile dressing that's wet with sterile saline. Transport properly, have them or yourself, depends on if they're conscious or unconscious, apply direct pressure to control any types of bleeding. Try to save and preserve the avulsed skin. Amputation of the penis shaft. Managing blood loss is the top priority. Use local pressure with a sterile dressing on the remaining of the stump. I didn't know it was called a stump. I learned something. Never ever apply a constricting device, so a tourniquet is out of the question. Surgical reconstruction if possible. If you locate the amputated part, wrap it in a wet, sterile dressing and place it in a bag. I don't know how you would walk into the facility and be like, hey, what's in the bag? Don't you want to know? I would be the guy. I'd be like, oh, look, we brought you lunch. Just because that's who I am. I would try to make a joke out of it. If the connective tissue surrounding the erectile tissue is severely damaged, the shaft can be fractured or severely angled. Sometimes require surgical repairs associated with intense pain. So when they say that the penis has been broken, it's not, there's no bone, so you're not going to break it. But what you're doing is you're damaging the shaft of there and those muscles. It's just like a muscle sprain, but they call it it's a broken. I've seen this surgery once. Thought it was pretty interesting when I first heard about it, and I said, nope, I'm good. I don't want to do it again because it's super duper painful. When I was with the patient after the fact, I was like, oh God, I didn't even want to ask the guy how it happened. Well, see, and I think that happens more in animals than it does in anything else. Plus, it may be your throat. Now, I say that that was the one of the person that I've only ever known that it happened to. So I was like, oh yeah, I gotta watch this. No, I don't. I should have never done that. That was my conscience trying to teach me something, and I wish that I never listened to it. So accidental lacerations to the head and the penis is associated with heavy bleeding because remember, it's very venous. It's going to bleed. Skin of the shaft of the foreskin can get caught in the zipper of the pants. I don't know how else to address that. Where they make underwear for a reason. I know, Caesar, this does cause PTSD. I feel you, bro. I feel you. It's traumatic. Why do you think I despise teaching certain portions of this entire chapter? I don't mind teaching this. I despise teaching OBGYN. I hate it. So that's not the reason why I skipped it that night, but it just so happened to work out right. So the urethra injuries as a male is not common. Lacerations of the urethra can result from straddle injuries, pelvic fractures, penetrating wounds to the perineum. It is important to know that the patient can urinate if there is blood in the urine. Save any urination for later examination by the hospital. It's okay. They will be able to tap the kidney and get it out. Any foreign bodies protruding from the urethra will have to be surgically removed. Not my job. I am not going to do that. Avulsions of the skin to the scrotum may damage the scrotum contents. Again, it's not my job. I'm just going to take you to the hospital. So the best thing we can do there is just keep everything wet and take it with them to the facility. Apply an ice pack to the scrotal area during transport because ice is a vasoconstrictor, so it will help the blood vessels constrict and potentially stop bleeding on its own. So that's something that we want to try to do. We do want to try to take this with us, so in case there's any traumatic issues or injuries, that we can help prevent that and it's being associated and transported with the patient to the medical facility. So for female genitalia, treat lacerations, abrasions, and avulsions with wet, sterile compress. Use local pressure to control bleeding. 99% of the time, that needs to be handled by the patient themselves. Please don't ever be seen holding that as you open the back of the doors at the hospital, because that is not going to look good for you. It's just not. It's going to, just don't do it. That's the best I can tell you. Let them hold pressure to the outside of the vagina. Do not pack the dressings into the vagina. That's not where it goes, and it's not going to do good for you on the end of it. Female genitalia, injuries are painful, but generally not life-threatening. So in hospital evaluation it says there, must happen. Transport urgency depending by associated injuries, the amount of hemorrhage, and the presence of shock. This is not a life-threatening injury, but it is a injury that needs to be assessed very quickly. We don't want it to wait for a couple of days, maybe have some long-term potential injuries or, some life-causing issues there. So if you know that that's been there or it's been caused, you need to treat them and try to talk to them and go into the facility. Rectal bleeding, that is part of the common complaint. This is possibly included by sexual assault, rectal foreign bodies, hemorrhoids, colitis, and ulcers in the digestive tract. Significant rectal bleeding can occur after hemorrhoid surgery. I will tell you through here, it doesn't talk about that. You can also, it has been I had this call probably 8-9 months ago. Go for abdominal pain, there's bleeding. She wasn't sure what's going on. She was very sketchy, but her mom and dad were just all over it. And I was like, well, let's just say she wasn't very honest to mom and dad until we got in the back of the ambulance. And I was like, hey, girl, listen, I need you to be very truthful to me. Did you potentially try something new tonight? Oh, no. And she got really embarrassed, really quiet. And I was like, listen, I don't care. I could care 10 cents less, but I don't really care what the problem is. But you need to think about anal sex as you go through that too. It can have an abdominal pain, it can cause bleeding, and some can be so painful that they're unable to walk, and that's where your calls come in. And again, when they're not very honest to you, you can tell. You can tell by their just their answers, because we're all in EMS after so long. You're like, they a lie. I swear we have like built-in lie detector tests. So just be knowledgeable about that too. Sexual assaults and rapes are all too common, unfortunately. Sometimes men and children are the victims. Often there are little that you can do beyond providing compassion and transport. That's really, we as EMS providers can't really do much ever else. Follow your protocols. That's best I can tell you there. If it is a crime scene, do not destroy the crime scene any worse than you have to. Go in one way, out the same way, and it's always best to let PD be there with you, just so they can document the scene. Now, if you have to take the patient out of the scene and you have to cut their clothes off and then try to save their life, that's fine, but please do not ever cut through a bullet wound or potential penetration on the clothing. Cut around it and save those and stick them to the side. We see that there. Make sure the same gender of the patient, a male or female, is taken care of, a male or female. Treat medical injuries and provide privacy, support, and reassurance. there's sometimes that we can't just lie to them. We're not going to be like, oh my God, you're going to be so much better in a few minutes. No, you're probably not. But don't lie to them. Don't make them know. I'm going to stop my share screen for just a second, y'all. I got to pull up the other video. We don't want to lie to them. We just don't want them to know that it's that we just be very truthful to the patient, to where when it is time that we, oops, I'm sorry, I'm trying to do two things at once, and then just let them know I'm going to do everything in my power to. Hey, can y'all see that video on there? Oh, hang on. Hey, what can y'all see on your screen?
Your face.
Oh, isn't that so nice? And I'm gonna start doing that more often. What's it showing? Because I can't get this to show what I want.
I can
see
see
the guy
video.
sitting on his knees right there.
Yeah.
Okay. All right. Good. So this is the one we're gonna watch first, because this is the shortest one, and then the next one over here is gonna be the it's gonna be a longer one. But I like this guy a lot better. I actually watch him a lot. So I'm gonna unpause this. Please let me know real quick if you can hear him, because I don't know if I've hit, if you're gonna be able to hear it. So don't mute your mic until I know that this is good. Can y'all hear that?
No.
All right, stand by. I saw this a while ago. Share computer sound.
Yeah, I was fixing to say there should be an option where you can share the.
Okay.
Can you hear that?
Right there on the board is
Yeah.
what we're gonna go through.
Right.
And then you all can practice. Right. They're pretty straightforward. Nothing much to them. Right. The first one I want to show you is the abdominal evisceration. Right. There are two different methods for managing this injury. Okay. A wet method or a dry method. Okay. For the most part, we all practice. Myself, Gary, Jeff, Carrie, all of us practice the dry method. Okay. Now, with an abdominal evisceration, what's going on?
Intestines
It's
are.
got organs, exactly. Abdominal organs protruding. They're hanging out. They're showing. All right. So what we're going to do first, all right, is first stabilize. Okay. So I need you to come down here and basically stabilize. And this is if any abdominal organs are out. Okay. You pretty much keep them from. Yeah, there you go. So we need to pretty much keep them in place from sliding around. Depending on how much, they could fall off and be on the ground or whatever. Okay. Are we going to put them back in? No. All we're going to do is stabilize in place, right on top. Okay. Now, right here's what we've got simulating that. So for the most part, what your job is with gloves on, right, is to keep those kind of stabilized. First thing I'm going to do is find an occlusive dressing. Okay. An occlusive dressing does what? Seals it off. Seals air. Okay? Now again, wrapping anything in plastic, what are you going to do to lie inside of it? Sweat, right? So the whole idea with plastic or the abdominal organs is it's going to keep them moist. Okay? The abdominal organs are already moist. So we're going to place that over top. My partner here is going to hold that in place. And then the next thing we want to do is maintain body temperature. With as much surface area, the abdominal organs protruding, there's a lot of heat lost, okay? So what we're going to do is basically, while he's stabilizing, I'm going to layer for warmth trauma pads over top, okay? I'm going to lay this one right here over the middle. I lay this one kind of overlapping to one side. This next one overlaps to the other side. That way we don't have any openings. Everybody follow me there? All right. We're going to take another one and basically secure all of them together. Work for you? Yeah. Okay. Now, what can we use to secure this in place? Bravats. okay? The cravats, which always, the first rule, I know you all learned next door, we always do what with the cravats?
Fold them.
Fold them, right? So same thing, fold the cravat. Now, to secure this, where's their natural void already?
Under his back.
Exactly, the lumbar region of the back, right? We already have a natural void. We're going to take these and fold them. Okay. Need 2 of them. Anybody seen the trick with using a board split to actually pass them under the back? Seen that before? Now again, this particular type of injury, what else do we want to be aware of? We've already got an injury to the front, what could possibly be going on? Okay, could be penetrating through the back, so again, that's why we check the back, right? Okay.
We're not worried about the thigh. Okay?
So just kind of a trick to make things a little easier. Take both the cravats, folded, and we're going to pass them underneath the lumbar region. There you go.
I think I might twitch.
Yes. All right, now my partner can catch those on the other side, right? I'll pull the board out. Now, what you all are gonna, what we're gonna be pinging on you all later with is anytime you're wrapping anything or splinting or doing any of these types of things, we don't want to see you moving the patients. No excessive movement. So when we're securing these cravats, all right, we'll find out which one's which, separate them and scissor them back and forth. That way I'm not moving him around. Okay, scissor them back and forth. And then we want to secure this, move your knee.
Everybody tied to me.
It looks like it's really tight. I don't know if you can find a good place to let that.
Secure this off to one side. Okay, don't tie it directly over top. That's where the organs are sticking up, right? So secure it off to the side with your surgeon's knot. Pull it secure, and then safe to your knot. What do we always do with the tails? Tuck them in. Okay. Same thing with above. Scissor it back and forth. Basically, really all we're doing is a pouch. Now, where I secured on the right side low, I'm going to go the upper side high. I see that? Make sense? Tie it off.
Is it just to secure it, or are we going to do a slightly tighten to?
Just secure it. Secure it. Okay. Now, the last thing we can do here with this type of injury, because of what's already been penetrated to allow the organs to come out, is the abdominal muscles have been torn. Right? So if you flex at your knees, bring your knees up a little bit. Does that take some of the tension off the abdomen? Okay. So that's all we're doing. I got that? Okay. Remember your knots off. Okay, doesn't matter which one's which as long as they're opposite of one another. Okay? Plastic, and then keep them warm. That's all it is. Okay, flex at the knees.
They ride like that?
Sure.
Never over.
All right, so I'm gonna go ahead and play the second one. So give me just a second. And again, this one, y'all, is, I don't know what to do. Hang on. This one is going to be the longer one of the two, and it is about 15 minutes. And after the 15 minutes is up, we're done. So I'm gonna let y'all see that. And again, somebody please unmute and make sure that you can hear everything.
Hey guys, welcome back to EMT Made Easy. So this one is made for Mia. So a shout out to Mia. She requested that I redo the abdomen video because of the music in the background. I was trying to be goofy, it didn't work out. All right, so a few things. Just kind of broadly cover the solid organs and the hollow organs, and then talk about blunt trauma and some considerations in regards to the abdomen, and also penetrating traumas and in regards to the abdomen. I'm not gonna cover every single little thing though. All right, so first things first, we have two types of organs in the abdominal region. We have your solid organs, so that would entail like your liver. So this right here is your liver. Then you have your pancreas kind of tucked in underneath behind the liver. Your spleen is kind of on the left side of the patient. Now, remember, it's very important that when we're talking about a side, like for a patient, we're talking about their side. It's never our side. So if I'm looking at the patient like this right here, right? So we're looking at the patient from our angle. Now, if I say it's on the right side, I'm not talking about my right. I'm talking about the patient's right. So now that's very important to remember just throughout your medical career, because it'll confuse a lot of people. So remember, it's always the patient's side, not your side. All right, so all that being said, yeah, so we have solid organs and we have hollow organs. Now, the biggest difference between solid and hollow organs, just as far as the EMT goes, that's important to us as EMTs working down in the medical field and EMS, is that hollow organs aren't very vascular. They're not vascular, so what does that mean? That means that they're not gonna bleed out as bad. They won't bleed out as bad. On the other hand, now your solid organs, they're very vascular, so that means they have a lot of vessels. They have a lot of blood in them. So if you actually injure those organs or rupture them, they're gonna bleed a lot. Now, just between you and me, not bad. So now from your thoracic cavity, so thoracic cavity means your chest, is up here supposed to be your chest. From your thoracic cavity down to your pelvic region, your pelvis would be like down here below. We can actually lose up to about 13 liters of blood. That's a lot of blood. We only carry between 5 liters to 6 liters of blood, depending on your size, okay? So that's a lot of blood. So if we rupture one of these solid organs and they bleed out, that's a pretty big deal. Now, just to kind of break it down even more, in your pelvic region alone, you can lose about 3 liters of blood. In your thoracic cavity, your chest, you can lose another 3 liters of blood. Like, that's how much you can fill in that thoracic cavity. So then whatever's left over can actually fill up in your abdomen. Now, I said you can fill up to 3 liters of blood here and 3 liters of blood down here in your pelvic region. Well, in your stomach, you can obviously fill up more. So about roughly 6 liters of blood can fit in your abdomen. But you actually won't even notice that your patient is bleeding out in the abdominal region, at least physically. You won't be able to tell physically from just looking at the stomach until they lose about 3 liters of blood. That's when you start seeing bruising, swelling, distension, and your patient's gonna start going through shock at that point if they haven't already done so, because we don't really start going through shock or like start showing signs of real bad shock or declining shock, decompensated shock, that means we're crashing, until we lose about 20% of our blood. So if we lose about 3 liters of blood, that's well beyond that 20%, right? We're talking about 50 plus now of blood loss in the abdominal region. That's why it's such a big deal. All right, so we kind of figured out that hollow organs are not very vascular, right? Solid organs are very vascular, so if they bleed out, they're gonna bleed out a lot if you rupture one. Awesome, we got that. Now, I'm not gonna go into crazy detail about where every single little thing is. There's no point in this little video. That's up to you. But I am gonna leave you with something that might help you out. And this should help you out throughout your entire career here. Remember this. All of your solid organs, for the most part, are gonna be on the upper side of your abdominal region, right? On the top side of your abdomen. All of your hollow organs, for the most part, will be on the lower side of your abdomen. Now, your abdomen is broken up into 4 quadrants, 4, right? Quadro, if you know Spanish or Latin. All right, so I'm gonna divide them up right now. So this right here is what divides both sides. Can you see that? Yeah, you can. And then your belly button will be like right here somewhere. And then this line right here separates top to bottom, all right? So let's say, also by the way, this right here, I'm gonna put an arrow on the chest, is the right upper quadrant, all right? This right here, this quadrant is the left upper quadrant. And then guess what these are called? What? Right lower quadrant and left lower quadrant right here. So all of your solid organs for the most part are going to be found in your right upper quadrant and left upper quadrant. If you know that by looking at the patient, the mechanism of injury, where the bruising is, you kind of have a better idea of how bad this is going to be. Prepare yourself right now. If you go, let's say you go to a car accident, the guy's leaning over the window, over the steering wheel, let's say that, and you see a big old bruise right here, right below the thoracic cavity, right? But it's in the upper quadrants, both of the upper quadrants. I'm thinking like, whoa, this guy has a big old bruise right here. Let's say he was maybe going like 40 miles an hour because that's what the speed limit is. Let's say he was doing that. Like that's some significant force behind this right here. If he has a bruise right here, I'm thinking he possibly ruptured his liver. That's very vascular. His spleen, which could cause peritonitis, a lot of irritation. We'll get into that maybe in a different chapter or different lecture, my YouTubes. But yeah, but just take that home today. Just put that in your back pocket. All right, remember that. Your solid organs are going to be found in the upper quadrants. Cool. And then your hollow organs are all going to be found in the lower quadrant. And we have right upper quadrant, we have left upper quadrant, we have right lower quadrant, and we have left lower quadrant. All right, so now that we got this out of the way, kind of talked about, you know, where somewhat the solid organs are and stuff like that. You know, your liver's up here. Your liver's more on the right upper quadrant side, but some of it does extend into your left upper quadrant. Now, if you want to reference this and kind of get an idea of what is where, if you kind of want to pause it and you just look at the abdomen, I kind of color coded everything for you. So but not every single organ is in here, okay? Remember that. If they're in solid color, that means they're solid organs, okay? If they just have the lines in here, just lines, they are hollow organs. So for example, this big light green thing right here, that would be your large intestine. That's what that represents. And then this whole bunch of little swirly mess of purpleness right here, that's supposed to represent your lower intestine, okay? And then that's your stomach right here. And then you have your pancreas underneath, tucked in behind your liver, like your big old liver right here in orange. You have your spleen over here. It's like in a pinkish color. And then your gallbladder would be like right here too, like right underneath. So I use brown and black. That's your gallbladder right there, somewhere in that region. But this is to give you a good idea of what's going on. Now let's talk about trauma. So just in general, when we're talking about EMT, so we're keeping it basic, right? This is an EMT mini lecture. When we're talking about the abdomen and trauma, there's only two types of trauma for EMTs that you should know about. There's blood trauma, and then there's penetrating trauma. Now just to put it in perspective, let's say you're playing baseball. You're playing baseball with little Timmy. You pissed off little Timmy. Little Timmy hit you with the baseball bat in the abdomen, but it didn't break your skin. That's called blunt trauma. You were hit, there was an impact, but the skin is still intact. I hope you get that. Now, let's go ahead and say, I don't know where you live. Maybe you live in Fresno, maybe you live in LA or Cincinnati. But let's say you live in the rough neighborhood, right, of that city, the little rough area. You're going to McDonald's, you just got paid. Hey, I'm gonna get a Big Mac. So when you go to McDonald's, you get your Big Mac. You're walking outside, you're happy, you get your little Big Mac, like, oh, I'm gonna go eat this Big Mac, it's gonna be an awesome day. And then some gangbanger comes up and shoots you in the abdomen because he wants your Big Mac too. So that bullet that's going, that's the bullet, by the way. That's the wind, the force behind the bullet. It's gonna be going through here, blah, it's going through your, everything, through your liver, your stomach, maybe even your spleen. Why not, right? It's already a bad day, let's make it worse. That is called penetrating trauma because it's penetrating your abdomen. Now let's get deeper into this. We're about to get into physics here, people. Brace yourself. All right, so let's stick with this. Right now I'm in penetrating trauma. So, and you will see this in your chapters. Most books have this. There's something called cavitation. Now, when you think cavitation, I think cabbage, so it doesn't make sense to me, but then I rethink everything. So think cavity, like a tooth, you know, that hole is a cavity, right? So whenever you have an object, a projectile, that's going, a rifle, let's say it's a bullet from a rifle, that force, that bullet is creating force that extends beyond the bullet itself. It's like, there's force behind it, right? So there's force behind it. So as that bullet is going through your abdomen, not only is there going to be damage in the pathway of that bullet, but also from that force that extends outward from that bullet. And that's called cavitation, because a cavity is a hole, right? So that force is creating a temporary cavity, like an oral cavity or your mouth, your nasal cavity. It's a cavity, it's an opening, it's a big space. So that creates a cavity. Well, that cavity, the force that's creating that cavity can actually rupture something else beyond that pathway. So it could maybe possibly rupture your gallbladder. Let's say it missed your gallbladder. It could possibly rupture your pancreas just from that force itself. Maybe even your small or large intestines. So that's what cavitation is, all right? So that's pretty much penetrating traumas, and then what can happen after the fact in a nutshell. Now let's go into blunt trauma. Let's go back to little Timmy in the baseball game. So after you pissed off little Timmy, he hit you with the baseball bat, right? Okay, well, let's say he hit you. That force was not, that force that was behind that bat was not strong enough to actually pierce your skin, to open the skin, to cause you bleeding, right? But that doesn't mean that that force wasn't strong enough to actually rupture a liver, rupture a spleen, all right? So this is where we get into physics some more. Energy is not destroyed. So once this hits my hand, it doesn't stop there. The energy continues through my hand. It might be diminished, but it continues. So if that baseball bat hits the side, let's say it hits you like right here on the side, right? That energy is going to continue to go. And if it's strong enough, it might rupture something inside. So if you ever have any kind of blunt force trauma in your patient, that's a tricky one. That's the one that really sucks, because you really don't know what's going on. And you see bruising up here, like bad bruising, always assume worst case scenario. So assume like, hey, this guy might have a ruptured spleen, a ruptured liver, depending on where the location is. So that's why it's good to know where they are, but I just don't expect you guys to learn the locations off my video. That's up to you. I just want to give you a general idea of where everything's at, the landscape, right? So upper, lower, upper is more solid, lower is more hollow. If you know that, now you can break it down even more on yourself, reading the book, stuff like that. So that's it with trauma, that's it with the regions, the quadrants, and all that stuff, and the liters of blood. So the MOI, mechanism of injury. The mechanism of injury is a hint, it's what happened. So as I approach the car, before I even get to the patient, I see this guy is laying over his steering wheel, right? Because it was a head-on collision. Now the MOI is gonna tell me like, damn, this guy is gonna have like some kind of trauma to either his chest, his head, chest, or abdomen. And then when you get there and you do see bruising right here, the MOI proved me right. And now I gotta think even deeper, like there's gonna be some bleeding possibly, so let's get going, because I can't do much. Not even a paramedic can do much out there for a ruptured liver, nothing at all, you know? So things to consider, things to know. And if you have any questions, just put comments down there below. Like I said, this video was made strictly off of one of the comments from me. I shout out again in case I forgot. You're awesome. Thanks for your comments. I really appreciate them. And I will be making another video on BVM, airway management.
Stand by. I don't know how to hit pause here. Let me get back to my headset real quick because I can't hear nothing. All right. So now I got you guys. All right. So look, that's really it. I hope everybody got some good out of this. I thought the last two videos were pretty helpful. That's the reason why I added those in there. Oh, you need me to share my screen again so y'all can see the code. Sorry. All right, so I'm just gonna say this is your class code coming up next. It is, oh, stand by. Caesar, stand by. Let me, I'll send it to you. How about that, if you don't mind? Let me text that to you because I had to go back and pull it up. Dude's very, very knowledgeable. He has some good stuff. Some of the stuff he's in there is like, I've watched a couple of his videos. He's pretty good. I've got it saved on my desktop, so I don't know. So look, so here's your video. I mean, here's your class code. I want y'all to know that I particularly made this for one particular person, and I'm gonna love as this class code has to get typed in by this particular person because they have to state the truth. So does anybody have any other questions, concerns, or anything? Hey Colby, you here?
Yeah, I'm here. I'm waiting for this class code.
Yeah. Look, you ready for this? So this is what you're gonna have to type in.
I'm not typing that in.
Well, I'm just letting y'all know that's your code. I mean, you got to type it in. I mean, that's the best I can do for you, bro. Just stating the
Ain't the
fact.
best you can. Nah, that ain't the best you can do for me. But all right, I'll type it in, I guess.
Couldn't help it, man. I gotta mess with y'all when I can. All right, so listen.
Yes.
Other than that, sorry. Let me back that up. I hope y'all have a wonderful night. I will see y'all Thursday night, and we'll get going from there, and we'll cover some more. And don't forget, we almost done, folks. So it is great, Caesar. I like to mess with y'all anytime I can. So we will see you Thursday night. I'll sit here and mute. Caesar, if you'll hang on just a second, I'll get that information for you. And if y'all have any questions, I will try my best to answer them for you. Other than that, y'all have a great night. Hey, Caesar. If you'll type that in, I have it saved as that. He's the very first one that pulls up. It's EMT abdominal anatomy and abdominal injuries. His name is JM. I'm not sure on how to. I mean, once you just type in that, like I said, he's the first one. If you hit subscribe, or there's a couple other ones. Like the next one down from him is EMT soft tissue trauma. You may know a lot more about YouTube than I do, but check there. And then if you don't find that, please let me know. All right, cool deal. Thanks, buddy. You have a wonderful night. I'll talk to you Thursday.